My name is Wendy Orchard. I am the Executive Director of the International Association for Suicide Prevention. And we're here today to have a session on suicide prevention. I'm delighted to be invited to chair this session for the Global Mental Health Action Network's annual meeting. I'm just going to give a minute or two for participants to join. I know people will be jumping in from previous sessions. And whilst we're doing that, I'll give you a little bit of housekeeping. It's going to be a panel session, so I'll be asking questions of our panelists, who I'll introduce you to shortly. However, I also want to hear from you, so please put your questions in the Q&A function, and we'll get to your questions as well and share those with the panel. As we start, I just also want to take a moment to emphasize self-care. Suicide is a tough conversation, a tough subject to talk about, and it's really important to practice self-care, take breaks. A lot of you will be on online on Zoom all day, and check in and reach out to those around you. So take breaks, check in, and practice some self-care. As we start the session, I would also like to acknowledge all those attending with lived and living experience of suicide and the knowledge that they bring to these sessions and to our work. So thank you. I'm going to give you a little brief, just very brief introduction to suicide. It's a complex subject, and then introduce the panel who are going to talk about different elements of the activities and actions that they get up to. So as an introduction, many of you will know an estimated 700,000 people die annually by suicide. And that is one in 100 deaths a year. So it's quite an extraordinary number. And each of those who die by suicide have leave behind loved ones who have also a profound effect on them. Also, we know that many more attempt suicides. We estimate again about 25 times. And those who are struggling with suicidal ideation need our help and our compassion too. So it's a very important subject. It's a very important cause, and it's some very important work that we and you are all involved in. So thank you for attending. Suicidal thoughts are complex, and there's no single approach that works for everyone. Certain factors, be it mental health or social factors, can make someone more vulnerable to suicide, and we are still learning very much of what those factors are and what also resilience, how resilience can work, and so on. So there's a lot to consider. There's a wide range of factors, and therefore we believe there's also got to be a wide range of actions. Firstly, to reduce stigma, to help those who are struggling to reach out, but also a wide range of well-informed actions at community and national level that we can integrate cohesively to help reduce suicides. We have an excellent panel here today. I'm really delighted by those who've been able to attend and give some time, and I'm going to introduce them now. So in no particular order, first of all, we have Annette Baker, who is an event organizer and community advocate in mental health and suicide. She founded the non-profit community organization Survivors of Suicide and Friends in 2012, and has served on the task force committee for Australia mental health since 2015. So welcome, Annette. We also have here Professor Rory O'Connor. Rory is a professor of health psychology at the University of Glasgow in Scotland, and I know him well because he's also the president of the International Association for Suicide Prevention and a past president of the International Academy of Suicide Research. He leads the Suicidal Behaviour Research Laboratory at the University of Glasgow, and he can be found on Twitter at Suicide Research. Professor Murad Khan is also here, another I know very well, a past president of the International Association for Suicide Prevention and a professor within the Department of Psychiatry at the Aga Khan University in Karachi. He was chair of this department from 2003 to 2013, and is also practices in the UK, having obtained a member of the Royal College of Psychiatrists. Dr. Alexandra Fleischmann is here. She works with the World Health Organization in the Department of Mental Health and Substance Use, and has been working there for 20 years. So she's very well versed in the global approach to suicide prevention. Milestones in her work have been the multi-site intervention study on suicidal behaviours and the resource series of booklets on preventing suicide, the GMHAN intervention guide on self-harm and suicide. All of these resources you can find on WHO, so please go to their website and have a look at those. And then we have Matthew Mutiso, the Executive Director of the Coalition Action for Preventative Mental Health in Kenya. Welcome, Matthew. Matthew has been a CSO and NGO in Kenya for a number of years, and is also the founder of the Nanga Support Network, an initiative that offers psychosocial support programs for inmates and correctional officers with a focus on addressing ACEs and legal reform. He also serves as a co-chair on the finance working group of this Global Mental Health Action Network. So those are your panelists. I'm going to start with a few questions. We're going to start with a few questions on suicide prevention in general, and then we're going to talk a little bit after that about decriminalisation, which is a major barrier to suicide prevention. So Annette, I'd like to start with you and ask if you would share a little bit of your story and your work at the individual and community level in Australia.
Yes, thank you. My story begins with my daughter Mary, who took her life in 2011. As a mother, and my husband Stuart, a father, we who are with Australians for Mental Health now, we back then were blindsided, like most people are, when a person dies, when children die by suicide. We found ourselves probably, unlike some parents, in a position where we wanted to do something. So we started an organisation, a not-for-profit, Survivors of Suicide and Friends, and for 10 years have hosted an event on the date of the winter solstice. We have a model in this event with three, probably we try to have lived experience speakers. And to break that up, we have entertainment, poetry and beautiful things like that. I believe, after lots of research, that is probably one of the only types of events like this in the world. And as Ali said earlier, as we met, he was on the event last night. So we have, in the last 2 years, live streamed. The year before, we had a virtual event during COVID. So that is my story. We are involved in Australians for Mental Health, who are who work with United for Global Mental Health. We talk to Sarah a little bit. Yeah. So is that enough, Wendy?
Thank you, and thank you for sharing your story. And also, I'd like to just follow up, and it will be interesting for those who are attending here who will do their own activities, whether it's for Suicide Prevention Day or other community awareness days. Have you seen that engagement in the community grow? Are people really wanting to connect?
Absolutely, yes. We don't tend to look at ourselves as, in the suicide prevention, but I think doing a post, we are postvention, but postvention is prevention and intervention. our community talks about suicide all the time, and that does not create suicides. We talk safely, we talk beautifully, and we have in Albury and Wodonga an amazing community that have these really hard conversations without any problems now. So yeah, and I feel really proud that to be living here amongst all of these people who can say that word, and it wasn't like that. I could not put posters up in 2013. People did not want to have much to do with the topics, so we have grown.
Wonderful. And it's a really important message that talking about suicide doesn't make someone suicidal. You're not putting people at risk. In fact, it's really important to talk about suicide. Professor Rory, I'm going to come to you next and ask you to maybe just give the group a little brief overview of some of the global suicide prevention efforts, what that means practically, but also with your experience, where research can really make sure that these are well-informed actions that we're proposing and taking.
Yeah, no, thanks, Wendy, and welcome. Delighted to be here as well. And I think maybe I start off maybe saying a bit about IASP, the International Association for Suicide Prevention. It's obviously Wendy is our fantastic chief executive, and what we try and do as an organization is really a number of different things. One is to be that global organization. I think we are that global organization, trying to promote understanding around suicide and suicide prevention, as well as ensuring that the best evidence is disseminated across the world. And a really important part of our role is really that advocacy and policy role at really trying to speak to, from governments down, looking at speaking to governments and other organizations involved or tasked with suicide prevention, but really, I think, trying to dispel some of the myths around suicide. And one already has been mentioned today, that idea about talking about suicide will in some way plant the idea in somebody's head. And indeed, if you look at the research evidence, if anything, it's the opposite. What we find is we can promote conversations in a way which are safe and appropriate. Actually, it can be the start of a life-saving conversation to get people to hopefully this support, or start that conversation so you can get some individuals, both those directly affected by suicide in terms of those who are bereaved, as well as those who are suicidal, and get the support that they need. But at a global level, though, a piece of work that we've been doing as an organization has really trying to establish regional networks. So as we know that suicide, although every single suicide is a tragedy, and as Wendy said, at least at the very minimum, we know 700,000 people die by suicide each year. But we know there are different rates of suicide, not only in different regions of the world, but of course in different countries and within countries of the within each individual country. So what we're trying to do with the work we do on the sort of regional networks is trying to get a better understanding of what is happening on the ground across the world, because we know that although most of the research sadly still is grounded within high-income countries, the vast majority of suicides occur in low and middle-income countries. Something like 77, depends which year the statistics, but between 77 and 79% of all suicides. So I think what we as an organization again try to do is we try to ensure that we're stimulating research across these different parts of the world, but also supporting organizations and individuals in suicide prevention efforts. And indeed we work in obviously in partnership with the World Health Organization, and Alexandra will talk about, I assume, the work that the WHO has done, but really trying to help support implementation of that best evidence of what we know works to prevent suicide. And I think that's a really important message, I think, for those who are not familiar with the suicide prevention field, is this recognition that suicide is preventable. Because I still meet people who think, what's the point in doing anything because you cannot prevent suicide? And of course, it's incredibly difficult to do so, especially on an individual level. But we do know that there are national and multi-level strategies and activities that can be both at a national level as well as on a local level, which we know are effective. And one of those might be looking at how restricting access to the means of suicide, because we know the evidence base is really strong there. If we can think of ways in which in different countries of the world, different methods of suicide are more prevalent, but if we can then work collaboratively with people on the ground in different countries, we can do that bit of the puzzle of restricting access to the means of suicide. I'll just say one last thing, Wendy, and then hand back to you. And the one last thing I think we try to do, certainly from a research point of view, is help people recognize that to understand suicide, yeah, it's preventable. It's not caused by a single factor. It's without question a public health concern. We need to look beyond psychiatric diagnoses to understand suicide risk. We need to understand the social and cultural context as well as the psychological context, because it's only through understanding that no individual, as John Donne said, the famous philosopher, no man or person is an island. And it's recognizing that when we're trying to understand suicide risk, we need to understand individuals within their social and cultural context. And that social context could be about inequality. That social context or cultural context could be linked to the criminalization of suicidal behavior in countries, which is adding stigma and acts as a barrier to help seeking. Or it could be more broadly and looking at the shame which a culture or a society is impacting on certain individuals with particular inequalities. And I think really looking at that diversity, looking at people who are more vulnerable because of their background, not to do with anything to do with them themselves, but people, for example, from the LGBTIQ+ community for increased risk of suicide, in part because of the way society is impacting on them. So that, I suppose, is maybe just a quick overview, Wendy, of maybe some of the things that we as an organization, as IASP, as also as suicide prevention researchers, try to do.
Thank you, Rory. And yes, it's really shown the multi-factorial approaches. And as you say, it's not just looking at the psychological aspects, but the social aspects. That really also leads very well into my next question for Alexandra in regards to some of the work that WHO are doing and their resources. And Alexandra, you worked particularly recently on the Live Life resource, which is trying to put simple, straightforward guidance on how to build a national strategy, or at least a strategic plan of an activity, whether it's community-based or otherwise. Would you tell us a little bit more about that?
Yes, maybe to start with WHO's work in suicide prevention and then coming to Live Life. So one area is, of course, data and statistics. So WHO provides the global health estimates for all causes of death, and including, of course, then suicide. So with the official estimates from WHO about suicide in countries, regions, and the world. Another area is, of course, the normative work with providing guidelines like the mental health gap action guidelines for assessment and management of priority conditions for non-specialized health worker, which includes a module on self-harm and suicide, so how to assess and manage people who are in need. And then, like you say, it's of course the work with countries, and here the Live Life comes into play. So we serve the WHO member states. There are 194 member states, and we try to support and help them to implement suicide prevention strategies. So, of course, there are some countries that do have a national suicide prevention strategy, but even those countries sometimes struggle with implementation. And on the other hand, there are countries who have not yet acknowledged suicide as a public health problem or prioritized the development and implementation of a national strategy. So we felt there is some guidance needed on having a starting point in implementing national suicide prevention strategies or starting suicide prevention at all. And Live Life in this way brings together the key effective evidence-based interventions to focus on. It's the key, a few to start with, not saying that's everything you can do. There's much more to do, of course, but how to start with something that can be grasped, that can be implemented. And so these 4 key effective interventions to focus on are reducing access to means of suicide, what we already have heard from Rory, then to work on responsible reporting by the media about suicide, then to foster life skills among young people, coping skills, problem-solving skills. And the 4th key intervention is to assess and manage and follow up anyone who is affected and needs help. So the last one would basically be the health sector response. But from the other 3, you immediately see that suicide prevention goes across different sectors. So it's not only the health sector being called upon, it's other sectors as well. And this is why to implement these key effective interventions, one needs to be able to also work on different pillars, or like the background, or what is necessary to prepare the ground. And this is multi-sectoral collaboration, this is capacity building, this is awareness raising and advocacy financing, of course, having the data available. So basically, I would say that yes, currently WHO is putting much more effort to support the work in countries.
Thank you, Alexandra. And again, it's really illustrative of the range of stakeholders that we need at community level, government level, across the different ministries. As you've said, it's not just healthcare, it's involving all of us. So thank you. And I'm going to come back to you very, very shortly, but I just want to make mention of the Suicide Decriminalisation Working Group as part of this global network, Mental Health Action Network. We do have a working group. It has been focused on decriminalisation because it's a major barrier to help seeking. And whilst that has been our focus, and I'm going to move the conversation a little bit onto decriminalisation now, I just want to do a little shout out because they are broadening their brief, and really everyone is welcome to join. So if you're interested, if you just please come along. United for Global Mental Health, Ali in the background can give you the details of how to sign up. But it's a really interesting group, and we are, as I say, broadening. So if decriminalisation is not really one of your factors at the moment, we'll be talking about suicide prevention in general as well. But to move on to the important also topic of decriminalisation, Alexandra, whilst I have got you here, I know that WHO have some plans in this respect because there's a policy brief coming. So can you tell us a little bit about the importance of decriminalisation and WHO's policy on
this? Sorry. Yeah. Yeah. So of course, the important thing is that people feel comfortable to seek help, and criminalization prevents people from seeking the help they need. So this is why WHO is currently working on developing a WHO policy brief on decriminalization. And they're actually in the Department of Mental Health and Substance Use, there are actually 2 teams working on that. So it's the mental health team where my work is located with suicide prevention, but another team where the work on mental health policy and service development is located. And so we are jointly working in 2 teams, and also have reached out to United for Global Mental Health and IASP. IASP, who is an NGO in official relations with WHO, to provide inputs to that. And so this policy brief is currently in the progress of being drafted, and there will be a consultation meeting, a broad consultation meeting involving people with lived experience, involving countries where suicide is still criminalized, but also countries that have recently or decriminalized, that have that experience of decriminalization, and then also of academia and research. So there will be a large consultation happening towards after this summer. That's the plan currently. And then with these inputs, the policy brief will be further revised, and then to have also a comprehensive international review. So we will seek for further inputs, so to have this policy brief really broadly reviewed and then released, and hopefully then to be able to work with countries concretely on decriminalization. Sorry for my voice. Thank you.
Thank you, Alexandra. Thank you. And I'm going to now move and ask Murad. Murad, you work in a country where suicide is still illegal. Why is suicide still illegal in so many countries? What are the background to the legislation, these legislations, and why is it a key priority? Murad, I'm sorry, you're on mute.
Sorry about that. Yeah, thank you very much, Wendy, for inviting me here. There are currently about 20 countries where suicide is still criminalized, and another 20 countries where the Sharia law is operational in terms of suicidal behavior. It's partly historical. 15 of the 20 countries where it is still criminalized are Commonwealth countries, so they were former colonies. And the law that was made around suicide has just persisted. And because mental health and suicidal behavior comes really at the bottom of the rung and has not gained too much attention, these have been kind of left on the sideline. So no one's paid any attention to that. So it is partly the colonial legacy in these countries. Partly it is ignorance. It's partly not paying enough attention to these issues. And then obviously there's this very strong religious element in the Sharia compliant countries. So it's a bit of all of this. In Pakistan, this is what's been happening. The Lunacy Act of 1912 was in operation for more than 70 years. In 2000, the new Mental Health Act came in, but it was not enacted until 2010. A clause has now been inserted in the Mental Health Act that anyone who makes an attempt and is deemed to be suffering from mental health issues should be assessed by a psychiatrist and not be punished. So that kind of provided some protection, but not total decriminalization. Recently, there's been a very positive development in Pakistan. Decriminalization bill was introduced in the upper house, the Senate. It was passed. It then went to the Islamic Ideology Council, which is an advisory body that comments on issues like this. They made some amendments and went back to the Senate, but the Senate did approve it. It has now been sent to the lower house, the National Assembly, where it is awaiting discussion. And we are hoping with the bated breath for this to be decriminalized. So it is a very important issue. And 4 countries that have recently decriminalized this suicidal behavior include the Cayman Islands, Cyprus, Lebanon, and India. And they've all used different approaches. And it's very important that we learn from their approaches. For example, in India, they tried to do so in a few years ago, and it was not successful. In 2017, they used a different approach, the mental health care approach of 2017, and within that framework, they address suicidal behavior as anyone who makes an attempt is considered to be under extreme stress and therefore should not be punished. So in India, it has been decriminalized by a different approach, and I think it's very important that we look at the experiences of some of these countries, including Pakistan, which we hope where it will be decriminalized. Thank you.
Thank you, Murad. And I do have a question from the audience on decriminalization in Pakistan. So I know we've got some space in about 10 minutes for questions, but as it's so connected to what you've just been talking about. The question is, Pakistan being, as you know, one of these countries where suicide is criminalized, how can I as an individual join the movement to decriminalize it? I know from the working group, and Murad, you've been connected with them, there are organizations like Tashkeen in Pakistan, but how would you recommend someone get involved in this movement?
Well, for joining any movement like this, I think the person has certainly expressed an interest, which is a very good thing. The second thing is really to inform and educate oneself. So there's a huge amount of literature around this topic of suicide prevention, decriminalization, and so on. Look at the literature and arm yourself and inform yourself, and then see the groups and organizations working in this area and join them. So I mean, these would be the one or two things. Write about that in the lay press, for example, raise the issue. But before that, it's very, very important to inform yourself. Thank you.
Wonderful, thank you. And Matthew, I'd like now to go to you, because you are also working in the community, in your country, addressing illegality of suicide. So can you tell us a little bit about the work that you're doing, some of the activities on the ground?
Thank you so much, Wendy, and it's a pleasure being here in this panel discussion regarding suicide. As an organization, we realize that suicide is attempt suicide is a criminal offense in the country, and so we've been part of the conversation to decriminalize suicide on two fronts. Number one is to educate the community. We are doing quite a number of advocacy programs through our memberships, which involve community-based organizations. At the moment, we have about 140 organizations. So we are trying as much as possible to see if we can have workshops with each organization under the coalition. Besides that, we are also doing infographic translations using different languages in the country. Kenya has about 42 local languages. So what we are doing is that we are reaching out to different public through different languages. We are translating the communication in different languages so that people can get to understand about suicide in their local languages, mother tongue. That is one in terms of advocacy, that we are going out to the public, and we hope also to reach out through community radio stations which speak different languages so that people can get to understand suicide and the various dynamics about suicide. The other thing is that as an organization, we have also been enjoined as amicus in a petition filed by the Kenya Human Rights Commission. We are part of this litigation process to decriminalize suicide. In fact, we were in court on Monday this week when there was a mention about the same matter, and the Attorney General presented his objections about decriminalization. The matter was adjourned up to October this year, where the hearing shall happen. So that's part of our efforts to decriminalize suicide. We've also engaged one of the sitting senator, who happens to have brought a bill in Parliament about the criminalization of suicide. We've also written to her and offer our support. Among us that, amongst other issues that relate to suicide in the country. So in a brief, that's what we are doing as a coalition regarding this matter.
Thank you, Matthew. And I know from hearing about your activities and other activities, the importance also of keeping going. When there are setbacks, it's important not to get too disheartened, but to keep going with this fight. It's not a quick and easy matter to deal with, but thank you for sharing some of your work. Whilst I have you here, can I just also ask as a little bit of a follow-up and a little bit of a plug to the Suicide Decriminalisation Working Group? Has being part of that group helped you with this issue and in suicide decriminalisation and your advocacy work?
Yes, indeed. For example, it's through the working group that we were able to get in contact with the International Association of Suicide Prevention, where you happen to sit as the CEO, Wendy. And what happened is that through the collaboration and with the network, we wrote a support letter to Senator Habshiro Alake, and she responded by saying that she was grateful. And at the moment, as Parliament has been adjourned because we are going towards election, we hope that if she comes back, because she's also contesting, the support that we had previously started working with her towards the decriminalization of effort will continue. And that's the beauty and that's the power of collaborating with different organizations, different associations. For example, the Prevention Suicide Association, Global Mental, then the network and so on. You get to learn from different people. You get to learn from different countries what they're doing. You get to hear even the different approaches that are there. You get to understand why there's a need even to decriminalize suicide. Yes, I must say that it has been very helpful for us to be part of this conversation and the working group in general. Thank you so much.
Wonderful, thank you. A reminder to all who are attending, yes, please put your questions in the Q&A. You've got this panel here, so let's make the most of it. Whilst I'm waiting for some questions and answers, I have a few more questions myself. So Annette, if I can come back to you. Whilst obviously suicide is not criminalised in Australia, and where it is criminalised, we have to take into account people's safety. I'd like to hear a little bit more about how persons with lived experience and their families can become effective advocates for suicide prevention, for reducing its stigma and sharing and raising its awareness.
Sorry, just unmuting there. Okay, Wendy and everyone, I, after 11 years as a survivor of suicide, I believed that the lived experience voice is invaluable for, you know, to be heard by many. And I do believe listening to the lived experience person does actually prevent suicides. I believe, you know, in our with our own experience, we have many people in the advocacy work that we do. We bring a lot of people on board with us who have the lived experience, have had a person die by suicide, and with that, I think it's the, you know, I think postvention is prevention, as I said earlier, and I cannot stress that enough. It actually it does help with the complicated, you know, as you all know, grief, suicide grief is complicated. It is difficult to navigate anywhere to find help. A lot of counsellors and whatever are not effective for people like us. In fact, I think we are effective for another person with the same. I've had people say to me, I need to talk to someone who has lived through this experience because that is going to be more helpful for me. And with that, quite often they go on to do advocacy work as well. So if that's making sense, yes. Yeah. It is a little. Yeah, go.
I was just going to say, peer support is a really wonderful, and I think more and more visible source of connecting and helping each other, and effective in this field and in mental health in general. Wonderful, thank you.
Thank you.
Whilst I also have the floor, I'd like to go back to you, Rory, and talk a little bit more about suicide prevention in general. To acknowledge also that we're coming out of a time with the pandemic, and we hope we're all moving forward and away from that. But where should the field and suicide prevention be focused as we come out of this last 2 years?
Thanks, Wendy. Maybe before I answer that directly, say something about what we know about the impact of the pandemic on suicide rates. So in March, April of 2020, many of us in the field of suicide research and suicide prevention were really concerned about the potential impact of this perfect storm of economic and social and psychological factors that the pandemic could give rise to. And our fear was that the suicide rates would increase. And so, and at that same time, David Gunnell at the University of Bristol convened this large group of not just researchers, but primarily researchers from across the world, and established the International COVID-19 basically suicide prevention collaboration. And we've as an organization, IASP, have been working closely with collaboration. And what's come out of that, and work also led by Jane Perkis in Australia, is that initially she was able to demonstrate, looking at or collating data from 21 countries initially, covering the early part of the pandemic. And the reassuring news was that, largely speaking, there was no evidence at that early phase of the pandemic of an increase in suicide. So that was really encouraging. But one of the messages we have in that paper is the importance of vigilance. And ever since that, Jane has now expanded this collaboration, which now has data from, I think it's 33 or 35 countries, covering the first, later in the pandemic, but still not right up to date. It's covering, I think, the first 12 months of the pandemic, or 12 to 18 months. And again, largely speaking, the story is positive in the sense that suicide rates haven't increased in most countries, but there are starting to be signals in some countries of suicide rates increasing. For example, in Japan, there's evidence of an increase in suicide. So what that highlights, I think, for us as a broader picture of suicide prevention as we emerge from this post-pandemic world is, although, yeah, thankfully thus far, the economic supports in place that many governments put in place have prevented some of the damage of the pandemic on terms of suicide rates. We also know from international surveys that although in most countries the suicide rates have not increased, there's clear evidence of an impact on mental health. Indeed, I've been leading one such study in the UK, which highlights that we know that impacts on symptoms of depression, of anxiety, of loneliness, of entrapment have all increased. And what's, in terms of going to your question specifically though, Wendy, what's clear from the data from looking at suicidal thoughts and suicide attempts and depression and anxiety is that we weren't all in this pandemic together. And there's clear evidence of certain groups of people being particularly vulnerable to mental health problems. And certainly that seems to be young people. women, people from more socially disadvantaged backgrounds, some people from minority ethnic backgrounds, as well as those with pre-existing mental health problems. So as we emerge from the pandemic, and that emergence from the pandemic will be bumpy, well, I think we need to really focus our efforts on those groups I've just mentioned. And again, taking a global lens and understanding that the impact in Japan or in India may be very different from the impact in the UK and the United States. And then just one last thing maybe to add to that when we think about the supports from the pandemic is we've known before the pandemic struck that the mental health of our young people was being adversely impacted. There's this growing trend of increases in suicide, increases in depression, anxiety, eating disorders, a whole range of mental health problems were on the increase before the pandemic. So it's important that we remember that although thankfully the suicide rates overall haven't increased, we need to be really careful, and I think in particular for young people, because I think the pandemic impacted on some of those young people's life chances, so they think, their education, and also those social networks, especially at times when they're developing their social development and emotional development is at that critical window, either in early life or through adolescence, where we've seen huge impacts. So I think the last thing I suppose I would say is, to that mind though, if we're focusing on young people, what access do young people have to services? And what are those barriers to access? We've known before the pandemic that in some countries of the world, including my country, waiting lists of 12 months or 18 months to see child and adolescent mental health services is not unusual. So we need to look at new models, I think, to ensure that the most vulnerable get the support that they need when they need it. And I think that's a challenge for us all as a field, because yes, we've looked to these new ways of working and digital interventions and so on, but I think we need to be careful that we are ensuring that yes, with these new ways of working, but are those new ways of working effective? Are they reaching the people they should be reaching? And crucially, are they increasing existing inequalities? And I think that's a big concern moving forward.
Thank you, Rory. In fact, we had a question, which I feel you've answered, as to whether suicidal ideation is a growing issue among adolescents, or are we just better at identifying it? And I'm assuming the answer to both is yes.
Yes, yeah.
Thank you.
I think, sorry, there is one, but I think there is probably part of the answer is we are better at identifying it, I think, or people are more willing to disclose. But I think all the research would suggest that even when you account for that, there has been this increase in suicidal thoughts and self-harm and suicide attempts over the last 20 years, certainly in countries where we've got reasonable data.
Thank you. And you mentioned cultural barriers. So I'm going to go to Murad here for another question from the floor. And Murad, what are the priority considerations or advice when addressing cultural barriers to limit the risk factors of suicide?
So that's a very important question, Wendy, because the problem may be global, but the solution always have to be local. And so studying local factors, looking at the local evidence is extremely important. And within that context, the cultural factors regarding stigma, regarding attribution of meaning to a certain act becomes extremely important. And in many of these countries, religious factors play a very important role, both in mental health, in attributing the meaning to a certain affliction, as well as to suicidal behavior. So those need to be addressed, those need to be studied very carefully and sensitively, and suicide prevention strategies really should reflect these things and bring them into consideration. Without that, if you were to piecemeal take a suicide prevention strategy developed in one setting and then try and apply it into the other setting, it will not work. And so one has to be very careful, and therefore the importance of local evidence is extremely important, and research looking at the local factors become paramount. Yeah, thank you.
Thank you. We have another question, Murad. I wonder if you can stay with me on this one, from Yvonne, asking, what are the opinions, what's your opinion on copycat suicide? So we talk about contagion sometimes and clusters. Could you just give a little, very brief, I'm sorry, response to that?
Yeah, I think it's a very, very important and a very disturbing event, particularly when young people are involved. And the effect of the media, particularly the social media, plays a very important role in this. And so one has to be very careful in how suicide is portrayed in the lay press, in the media, both the electronic and the print media, but also in the totally unregulated social media. So copycat suicides in such groups of people become really, really important. And again, the way to do that is one, education, one, communication, and to discuss about these topics which don't seem to gain as much attention as they can. So we really have to try and bring these topics to the fore to discuss that, not to normalize suicidal behavior, but to not feel hesitant in discussing these very difficult topics and having difficult discussions around them.
Wendy, can I just come in on one additional point on that?
Yes.
So just by one way of reassurance, of course, every death is a tragedy, but those contagion suicides which are associated with contagion, because we try not to talk about copycat in terms of language now, because some people find it stigmatizing, but is that it still represents a small percentage of all suicides. So it depends on which population. And young people, yeah, it's larger, but still it's between maybe 5 and 10% of all suicides in some sort of settings. So the challenge is still broader. Of course, we need to tackle those so-called copycat suicides, but we need to look beyond that, of course.
Yeah, thank you, Rory. That's it in context. So we've only got a few more minutes left, and I'm going to come back to each of the panel, but we have, I'm going to come back to you, Annette, first. And so what would you say one of the perhaps key messages you give to others with lived experience, families particularly, that you have worked alongside and are connected with in your work and advocacy?
One of the key, could you repeat that question? One of the key messages
that you use in your advocacy work, particularly with the community, with families.
Yeah. Well, once again, we get onto complicated grief of suicide. When a family is blindsided, which is exactly, how most people explain a suicide to us, you automatically, I think the family has trauma that they experience, and it is a time, and it is a learning of how these people can live their lives knowing that person has decided to take their life. So it's there's a lot of learning in a death by suicide, and I think we are, we have a lot more resources these days. We're lucky that, we have our postvention organisations here in Australia, and when a person contacts me, I put them in touch with as many suicide standbys, support after suicide, and many organisations that are well trained in talking to people after their person's death by suicide. So there's no right or wrong. There are some people that, remarkably are very very, there are actually, through a Roses in the Ocean group thing that I did recently, there were people that were actually okay with their person's death by suicide because that person had, it had been problematic for these people for many, many, many years. So they're all different, but I would not wish it upon anyone personally. Yes.
No, absolutely. But what I take from that is the importance of connecting and supporting.
Yes, and it doesn't have to be professional. It is that person that has experienced the suicide that is often the better person for initially, at any rate.
Wonderful, thank you. Matthew, I'd like to go to you and ask you for a tweet length answer to why is suicide prevention a priority issue?
Thank you so much, Wendy. I think from the word go from the previous inputs by the panelists, the rates of suicide have increased. The prevalence is also there amongst either adolescents and all that. I think this is a global issue right now. It's an issue, a health issue. It's an issue of justice. It's an issue of communities, and it's an issue of society. So ideally, with even without thinking twice about it, there should be a need for prevention of suicide death. Otherwise, ultimately, it'll become a way of life, and we'll be losing so many people on a daily basis, which is not absolutely good for our society. Thank you.
Thank you, Matthew. And Alexandra, I'd like to ask you the same question, but from your perspective at WHO on a global.
Yeah, why it's a priority. It's the sheer numbers. So maybe I'm leaning out of the window here, but it's more than 700,000 people dying by suicide every year. So let's say 1 million. And then if there are 20 times more making an attempt, that's, let's say 20 million. And then if you think that there are people around them suffering, the family, the friends, the colleagues. So let's say there are 3 to 5 people around them. So those 20 million, you don't have 60 to 100 million. I mean, this is just from the top of my head, like 100 in some way being affected. Each and every one of us knows someone who died by suicide or who made an attempt or who was affected by it. I mean, it's such a tragedy in your life. And it's so difficult to grapple with it and to come to terms with it. So it needs to be acknowledged that it is a serious global public health problem. There is global commitment because it is included as the only indicator for mental health in the UN Sustainable Development Goals for the year 2030. But still, action needs to be done around it. So it's this acknowledgement and to realize, yes, there is a problem. And then, of course, to take action, not to just make a strategy or plan or a program and talk about what could be done, but really to have it implemented. And here it's really a call to governments and to communities, to each and every one of us, because in the implementation, it's all of us here, those with lived experience, policymakers, anyone in the community who can help to implement and provide the help that is needed. Thank you.
Thank you, Alexandra. Certainly those numbers are breathtaking, aren't they? And it certainly shows the importance and why it's a priority. I'm just going to have to pull this to a close. So thank you to all my panelists. I know for this session will close on the dot in 1 minute's time. So just to those who are attending, thank you also for attending. The notes and recordings will be posted shortly. And the next webinar is on child and adolescent mental health financing, and we'll start in 30 minutes. So to register for that session, please use the link. It's in the chat now. So thank you to all my panelists. Thank you to all who've attended, and to Ali and Emma from United for Global Mental Health, who have facilitated this behind the scenes. Remember to prioritize some self-care today. Thank you and goodbye.